whereas there is very irregular dance-like movements. In all these movement disorders, the diagnosis is paramount. Most of the patients can be diagnosed just on clinical history and examination. In other cases, we have to get certain investigations done to rule out any secondary causes, because if there is any cause that is responsible for movement disorder, then that needs to be corrected, for which we have various investigations, including MRI, autoimmune panel, genetic testing. A lot of movement disorders are drug-induced, blood tests, and CSF analysis to rule out encephalitis. Management of movement disorders is, first of all, we need to treat the underlying cause. If we are able to find that underlying cause in the prior investigations, there are certain medications that can also be used for tremors, bradykinesia, rigidity. Botulinum toxins can be used for dystonia, stick disorders. There is physical therapy, and then there are surgical options. Now, surgical options are primarily divided into two types of options. One is stimulation procedures, and the other is lesioning procedures. The basic difference between the two types of procedures are stimulation procedures. They work by supplying electric current, and they are non-destructive. Lesioning procedures are destructive in nature. They burn out the aberrant circuit that is responsible for such movement disorders. So first we are going to talk about stimulation procedure, which is deep brain stimulation. It's a neurosurgical procedure that involves implanting electrodes in specific areas of the brain. It comprises of an implanted electrode and a pulse generator. It acts by delivering electrical stimulation to the brain, and it can also be called as pacemaker of the brain. Off-label, it has also been used for OCD, Tourette's, and depression. Now, this procedure has been FDA approved for tremors since 1997, for Parkinson's since 2002, and for OCD since 2009. Stimulation targets depends upon the primary symptoms of the patient, because if a patient is having more of bradykinesia, then different target is selected. If the patient is having tremors, then we select a different target. So all this is clinically correlated. Mechanism of action is it alters the abnormal neural firing. So what happens is the basal ganglia that is responsible for modulation of movements, the circuits that are there, they become aberrant and they cause abnormal firing of electrical impulses. So by providing stimulation, we do neuromodulation of the electrical signals, and this causes symptom improvement. This procedure is performed under local anesthesia, and there are various safety guidelines that we follow. The three important safety measures that we take are, there is intra-op microelectrode recording, which basically means that during the procedure, we record the local field potentials of the nerve cells so that we are 100% sure that we are at the correct place. Then during the procedure, we stimulate those particular areas, and we clinically examine to see if the patient is having resolution of symptoms and if there are any complications that are developing, so that these things can be corrected on table. So all in all, I can say that during the surgery only we know that the patient is going to improve 100%. The clinical impacts are, it reduces tremors, rigidity, and bradykinesia. It decreases motor fluctuation. It allows medication reduction and dependence, and improves quality of life. It has impact in other disorders also, like essential tremors. It causes major tremor reduction in dystonias. It is very effective in young onset generalized forms. This is a small video, wherein the first video we can see that the patient has a lot of tremors, and which is not visible in the video is that the patient had a lot of tremor and rigidity. And this is the second video, one day after the procedure, where the patient is able to drink water, which he hadn't done in a long time. Now, certain risks about the procedure. There's risk of surgical bleeding, infection, hardware issues. Very, very important is careful candidate selection, because surgery can be done in any patient, but we need to make sure that whoever we are operating on will benefit from the surgery. And another consideration is the cost of the procedure. Advantages, it can be done bilaterally, and programming can be done through remote. There is no tissue destruction. If there are any complications, then the procedure is totally reversible. And it is very good for progressive disorders, because as the stimulation carries on, the aberrant pathways are reformed. So as the disease progresses, we can change the stimulation parameters to make sure that the patient is symptom-free for a very, very long time, for up to 10 to 20 years. Now we're going to talk about the lesioning procedures. Lesioning procedures are divided into two parts. One, we are going to talk about the stereotactic lesioning, which is a very, very old procedure which has been going on for last 80 years. The pros of such procedure is it is a one-time procedure. It has negligible cost, and it's also performed under local anesthesia, as is deep brain stimulation. Even in this procedure, on table we get to know whether the patient is having any kind of symptom improvement or not, or if there are any complications, so that the procedure can be modified accordingly. It's a minimally invasive procedure where we use 1.2 mm electrode, and there is no permanent implant available. No permanent implant in such patients. Cons are that it's a one-time procedure and it is irreversible, and it is not so good for progressive diseases. But these procedures are very good for tremors or dystonia, wherein one-time procedure can cause curative treatment for the patient. Then there is a newer technology that we have called MRI guided focused ultrasound. Ganga Hospital is the first hospital in North India to have this machine. It does the same procedure as stereotactic lesioning, except it's non-invasive. There is no cut, we don't go inside the brain, but we are transmitting ultrasound waves through a helmet, as you can see in the picture. It's done in MRI machine, and there's a helmet that the patient wears. And through that helmet, we focus all the ultrasound waves to a particular target, which is monitored through an MRI. And here also, on table, we get to know what kind of improvement are we looking at. And the cons are the same as stereotactic lesioning, that it's a one-time procedure, and it's an irreversible procedure. And one of the cons is that it's slightly more expensive than stereotactic lesioning. So this was about the procedures that we have. There are newer techniques that are being developed. For example, in deep brain stimulation, there is something new which is upcoming, which is called as adaptive DBS. We are in an era of AI. So in adaptive DBS, what happens is that through those electrodes, they record the potentials, and the machine itself tries to decipher what kind of problem that the patient is having, and then they modulate the current. So you don't need even programming. Once the patient starts developing any other symptoms, then the currents are modulated through the machine so that the patient remains symptom-free even when the disease progresses. Now, combined approaches are more important than single approaches, because there are certain things for which lesioning is better, and there are other progressive diseases wherein the stimulation is better. So we should look for combined approaches. It's better to combine DBS and lesioning procedures for better patient outcome. Now, key takeaways here is these kind of surgeries are life-changing for selected movement disorder patients. Technology is rapidly evolving, and it should be given as a primary option for patients with progressive disorders. Thank you.
Thanks, Dr. Shrey, for a very nice presentation in a small time. And the topic is open for discussion. Any question from the audience?
So deep brain stimulation is it's very, very good, and has been proven really good for Parkinson's disease, because it's a progressive disease. So one-time procedure doesn't really help. We need to make sure that the patients remain symptom-free for a long time. Also, it causes less dependence on medication. So early morning stiffness, early morning rigidity and bradykinesia, all that is not there once the surgery is done. Cost depends upon the type of the implant that we are using. The electrode and the battery that we implant, the cost ranges from approximately 10 lakhs to 15 lakhs. One is a rechargeable battery, the other is a non-rechargeable battery. Then we can also control the direction in which the current is being delivered. So all that decides the cost of the implant.
It's quite expensive that way.
Yes.
And those patients who are not responding to the drug treatment, you select those patients in Parkinson's?
Sir, it depends. If the patients, they have good response, because we do a lot of UPDRS scoring before the procedure. wherein the patient is examined without any medication, then with medications, so that during the assessment we get a realistic idea what kind of improvement are we looking at after the procedure. Once we are 100% sure that the patient is going to benefit, then only we do the procedure.
Medicine is always the first line of management in initial patients, and accordingly, these procedures have to be used in a super selected patients, where we are sure about improving the quality of life. And it definitely improves the quality of life. We have seen patients, we have come across patients known as well as few doctors also, where it has made a remarkable difference in the quality of life.
Thank you.
So it's a combined team effort, but the assessment program is, the protocol has been set worldwide. So we follow the same scoring system, and based on the scoring system, we analyze and we decide whether the patient is going to benefit or not.
You see, all these treatments are not curative treatments. So where medicines are tried first, when medicines fail as the disease advances, there these treatments come into role.
Any more question?
Okay.
Thank you so
much.
much for
Thanks.
this very exciting session. Any question we have? Yes, ma'am.
Is there any food restriction for Parkinson's?
Ma'am?
Is there any food restriction
For
for
Parkinson's? No, ma'am.
Like tomatoes, very big tomatoes and all?
No restriction as such, ma'am.
Anything you'd like to add, sir?
So with that, we conclude this session. Thanks, Dr.
Thank you. Let's have a huge round of applause for this very new, exciting treatment for Parkinson's disease. Now we proceed to the next session on burning COPD with steam, bronchoscopic lung volume reduction. And for this session, I'd like to invite the chairperson, Dr. Ujjwal Parekh, sir, senior consultant in the Department of Pulmonology, Sir Gangaram Hospital, and Dr. Muhammad Wali, sir, professor emeritus and a very renowned physician. Dr. Abhinav, sir.
नहीं वॉल्यूम नहीं है वॉल्यूम बंद ही रखना अगर गलती से
Good morning, everyone. As we know, the incidence of respiratory illnesses are increasing because of various reasons. The incidence of COPD is also increasing. And with the increase of incidence of COPD, it's projected to be one of the most morbid and mortality-causing disease in the future. For last more than 2 decades, we do not have a new class of medicines which have come for the treatment of COPD. So we are just using the same medicines or better versions of the same group of medications. But for last 2-3 years, in our hospital, we have started a procedure which is helping those patients who are moderate to severe COPDs, who are having repeated exacerbations, by the use of invasive technique, which is a bronchoscopy. And Dr. Abhinav Guliani, who is our senior consultant, is going to give you insight about that procedure.
Thank you so much, sir, for the lovely introduction. I am Dr. Abhinav Guliani, and I'll be talking about how we treat COPD by burning the lungs. So COPD, as we all know, is a common preventable and treatable disease which is characterized by airway or alveolar abnormalities. It is usually caused by significant exposure to noxious particles, gases, and infections like tuberculosis. It is a heterogeneous lung condition, which means the lung uniformly is not damaged as a whole in many cases. It is the third leading cause of death worldwide, and it is a major cause of chronic morbidity because of lung diseases. A lot of money is spent on treating and managing COPD patients. So this is what the structural abnormality in COPD is, what we call as emphysema. So emphysema is destruction of the alveoli or the major functional unit of the lung. If it is along the septae, around, these are the septae of the lung, if it is around that, it is called a paraseptal emphysema, which leaves this lung nearly normal in comparison to the rest. Or it can be a panlobular emphysema where the whole structure of the lobe is destroyed. If you can see the depictory photograph over here. So in cases of both these patients, what happens is emphysema. If it is classical emphysema, which is panlobular emphysema, patients will present differently. If it is chronic bronchitis, it will present differently. This is how we've been taught. But most patients have mixed features. Emphysema primarily leads to hyperinflation, which compromises respiratory mechanism, leading to persistent symptoms. And as this photograph, what is hyperinflation? Hyperinflation of the lung is more size. It is pushing the diaphragm below the heart. The vessels are the periphery. This is a classical situation with hyperinflation. You can also see the red, which is the heart is touching the sternum. Here you can see the chest to be a barrel shape, which is classical hyperinflation. So how do we manage? We all know